Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Patterns in Use of Short-Term Complications of Breast Brachytherapy in the National Medicare Population in 2008-2009 by Carolyn J. Presley et al. My name is Thomas Buckles, and I'm the head of the Division of Radiation Oncology at the University of Texas MD Anderson Cancer Center in Houston, Texas. My oncology specialty is radiation oncology, and I focus my practice in research on breast cancer. Presley and colleagues provide us with an important health services research article that investigates the increasingly popular use of breast brachytherapy as an alternative to whole breast radiation for patients treated for early-stage breast cancer. I feel that this is a very important area for comparative effectiveness research, and that there remains insufficient high-quality outcome data regarding the safety and efficacy of breast brachytherapy as an alternative to whole breast radiation. While preliminary results of a small European Phase 3 clinical trial comparing brachytherapy versus whole breast have been recently reported, most U.S. outcome studies are modest-sized Phase 2 studies and reports from a registry database. A Phase 3 trial comparing partial breast versus whole breast irradiation, which is being conducted by the NSABP and RTOG in the U.S., is nearing completion of its accrual goal, but will not likely provide outcome data for many years. It is clear that despite limited long-term safety and efficacy data, breast brachytherapy has become popular treatment in many regions of the country. An earlier analysis of brachytherapy use patterns, which studied a national Medicare cohort treated between 2003 and 2007, found a utilization rate of only 3.5% in 2003-2004, compared to a rate of 12.5% in 2007. The Presley paper showed further growth in the popularity of this treatment approach. These authors analyzed the most recent national Medicare data that is currently available, a cohort of 29,648 breast cancer patients treated in 2008 to 2009. They found that 15.8% of the Medicare beneficiaries who received radiation after breast conservative surgery for an invasive breast cancer received brachytherapy rather than whole breast radiation. Moreover, they found significant regional variation throughout the U.S., with some regions, such as Utah and Louisiana, having up to a 70% utilization, whereas other regions had 0% utilization. Utilization was higher in metropolitan areas and in patients with higher income, and in those with greater access to medical care. The Presley et al. Manuscript also provides some important national outcomes with respect to short-term complications. These data are important because they confirm the results of a 2012 JAMA article published by Smith et al., who analyzed a national Medicare cohort of over 92,000 patients treated with radiation after breast conservative surgery for an invasive breast cancer between 2003 and 2007. The Smith article found a twofold increase in the rates of subsequent mastectomies for patients treated with breast brachytherapy compared to those treated with whole breast radiation. In addition, they also reported that both infectious and radiation-induced complications were higher with breast brachytherapy than whole breast treatment. Not surprising, this article generated significant interest in the lay press and significant controversy within the medical community. One of the important aspects of the Presley manuscript is that it independently confirms the finding of a higher rate of wound, skin, and infectious complications with brachytherapy compared to whole breast radiation. After adjustment for other risk factors, brachytherapy was associated with a 16.8% higher rate of complication as compared to whole breast radiation, which was nearly doubling the total rate. Due to the fact that the Presley analyzed only 1 year's worth of data, they were not able to analyze differences in late complications or rates of subsequent mastectomy. Both the Presley study and the previously published Smith-JAMA article have several strengths and limitations to consider. Both studies utilized a national Medicare database, which, unlike more commonly used SEER Medicare dataset, includes all Medicare beneficiaries in the United States. Accordingly, this unique national dataset permits analysis of a very large sample size. Combining the data from Smith and Presley studies provides toxicity information on over 11,000 patients treated with breast brachytherapy. In addition, these studies analyze practice patterns that truly reflect the overall U.S. quality standards of care. Such data is thus ideal for comparative effectiveness studies, which have as their aim the determination of outcomes associated with various treatment approaches in general practice, rather than in the controlled environment of a clinical trial or a single institution. A second major strength is that both studies provided insights on utilization patterns and showed how geographic and socioeconomic differences affected the adoption of breast brachytherapy. One of the significant benefits of breast brachytherapy and other forms of partial breast radiation is the reduction in treatment times from 3 to 6 weeks to typically 1 week. One would hypothesize that if utilization of brachytherapy was dependent on this benefit, that patients from rural areas who may live extended distance from treatment facilities would have the highest rates of brachytherapy utilization. Interestingly, the opposite was seen. Namely, breast brachytherapy use was highest in metropolitan areas, which tend to have high density of radiation facilities and serve higher income patients. Limitations of these two studies should also be mentioned. Both use claims data to determine complications, and therefore the grade and clinical significance of these complications are unknown. Secondly, brachytherapy requires a learned skill set, and introduction of any new technique and treatment may be associated with an early learning curve that is overcome with greater experience. In addition, brachytherapy technologies have improved and now permit greater dose sparing of the skin and superficial tissues that may have contributed to toxicities associated with the first generation of catheters. Finally, brachytherapy utilization has also been widely used in U.S. patients who are too young to be eligible for Medicare, and therefore, unfortunately, population-based outcome information on the younger breast cancer patients have not yet been reported. In summary, the Presley paper provided some insightful information about the dissemination of a new method of treating breast cancer and provided important thought-provoking information that both patients and providers should consider as they await the results of definitive clinical studies comparing partial breast techniques with the well-established treatment approach of whole breast irradiation. The paper also is a model for demonstrating how national comparative effectiveness research is an important complement to single institution efficacy and toxicity reports. This concludes my JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.